Good evening, everyone. Thank you so much for joining us today for SOFOA webinar. I'm Dr. Fatma Al-Hamad, and on behalf of the Saudi Oculofacial Plastic and Orbital Surgery Association and the Saudi Ophthalmology Society, I would like to warmly welcome you to today's educational webinar. Today's topic is targeted treatment for Plexiform neurofibroma, and we will be presented. It will be presented by Dr. Musa'ad Al-Yahya, consultant neuro-oncology at King Faisal Specialist Hospital and Research Center. Dr. Al-Yahya completed neurology residency and neuromuscular fellowship program at Case Western Reserve University in Cleveland, Ohio, and he then completed another fellowship in neuro-oncology at University of Virginia. He has extensive experience managing patients with neurofibromatosis and has contributed significantly to multidisciplinary care in his field. Dr. Musa'ad, thank you so much for being with us today. The floor is yours. Uh,
Allah.
yeah, and just before we start, I just want to stress on participants are welcome to submit a question throughout the lecture using the Q&A box. The floor is yours, Dr. Musa'ad.
Allah Khalik. Thank you, Dr. Fatma. We're really glad to be here with you today. Inshallah, this will be an entertaining talk, which is, I think, very important and something close to my heart. Thank you again for having me. So briefly, I'm going to talk a little bit about NF1, the unmet needs of it, and a little bit about the evidence based treatment currently systemically. And we're going to touch base on the referral pathway and multidisciplinary treatment setting in NF1. So I hope more physicians are aware of NF1, its burden and its prevalence. We all work in different fields, and when I meet trainees, senior trainees, and fellows, and I ask them, how common you think NF1 is, you get really large numbers, 1 in 100,000, 1 in 50,000, 1 in 500,000. Like NF1 is really not uncommon. One of the more or most common genetic disorders that we have. So it happens in around 1 in 3,000 people, and this number seems to be consistent in different groups and different geographical locations. So if you go to North America, Africa, Asia, it seems to be consistent. And the genetics of it is complex and long topic. But one other important point is that if someone, this is what I usually tell patients, their families, and even colleagues, if someone walked to me in the clinic with NF1, there is roughly 50% chance that this is inherited, and 50% chance that this is de novo mutation or alteration in that patient. So even if you solve consanguinity, NF1 remains pretty common genetic disorder. So now we have better treatment, and I think in the near future we'll also have more options. So this is something we've been working on to recognize NF1 and treat it as early as possible. It's a multisystemic disease. The phacomatosis or the neurofibromatosis, as you are probably aware, involve mostly ectodermal tissues, so it's mostly a nervous system and skin disease, but other systems can be involved, bone, cardiovascular, and so on. So it's a really, really multi-systemic, multi-phenotypic disease. and it's overall associated with lower life expectancy. This is also another important point that we need to stress on. The other relatively unique thing about NF1 is that the manifestation of the disease are not only variable phenotypically, but also they are variable age-wise. Some of these manifestations tend to occur in a specific age, and some can happen at essentially any age. At birth, most commonly you see the benign cafe au lait macule. You can see bone deformities, but other manifestation can occur later at age. To neuro-ophthalmology, probably or ophthalmology, the more important ones are the optic pathway glioma, which is around the age of 6, which but can be delayed to adolescence, and plexiform neurofibroma around the globe, which also essentially can happen at any age. But different manifestation can happen at different age, and also they can progress at different age. For example, you can have a small plexiform neurofibroma in a young age, but it can continue to progress and become a problem at a later age. And this is another important point in NF1. The diagnostic criteria has been with us for a long time, with few modification over the years. So you need to have 6 or more cafe au lait macules, and this is just a brief review on them. So these are the benign, darkish, non-raised skin lesion that can vary in number and size. They tend to be present at birth, but they tend to also can increase in number and size with age. And then you have the iris benign hamartomas, lesh nodules, and the more recently described choroidal abnormality, uh, both of which are of one criteria rather than two. Optic pathway glioma is another criteria, pathogenic enough one variant with a fraction of more than 50% is another criteria. 2 or more cutaneous neurofibromas or any type of plexiform neurofibroma, distinctive osseous lesions. So these are the sphenoid wing dysplasia, the bowing of the tibia, and the pseudoarthrosis of the tibia or long bones are also another criteria. And then you have the frickling in the axillary and inguinal region being another criteria. Now, in real life scenario, it's not always as simple as this. And nowadays, I think more and more centers depend significantly on genetic testing for these patients because sometimes S- rarely you can have two criterias in a patient that does not have NF1, especially if you have the cafe au lait and the freckles. Some cases, good number of cases have been reported with other diseases such as legions and so on. So these are criteria not 100% sensitive nor specific, but this significantly aid in the clinical assessment of these patients. So basically, for you to have NF1 diagnosis, you have to have 2 or more of the specific criteria in a child with a parent of of this condition. But if you have a child with a parent with diagnosis of NF1, you basically need one of these criteria to confirm the diagnosis. But as I mentioned, these are guidelines, and in specialized NF1 clinic, you deal with situation that does not really follow these criteria, but it's worth going about. Now, the choroidal abnormality, which has been included recently in as criteria with the lesh nodule, these are basically bright and patchy nodules within the choroid and often seen by OCT or NIR. They are typically similar to the lesh nodule. They do not affect vision, and they are basically a benign diagnostic marker. So the most important point is that the choroid abnormality account for one criteria. So with leash nodule, so if you have both of them, this remains as one criteria, but it's a good criteria. It has pretty high sensitivity and specificity. So this is probably one of the most important, relatively recent updates. The other one is the neurofibromas, and they can be cutaneous, they can be a little bit subcutaneous, but tend to be painful, not always, and then they can vary in number, they can vary in location, they can vary in size, and also in symptomatology. They can be painful, painless, or can remain painless for some time and become painful. So all of this is basically seen with these lesions. Patients who have heavy disease burden of these cutaneous neurofibroma tend, although not always, to have worse phenotype. So these are the patients that when I meet for the first time, I try to look for complication more aggressively compared to the those who doesn't have cutaneous neurofibroma. This is not really well investigated or well studied, but it's an observation that has been seen by multiple what we call now NF specialists or nephrologists. Um, and then you can have the plexiform neurofibroma, which are our main topic today, and these are relatively larger, more problematic tumors. They tend to occur in the midline, so it can affect the globe, can affect the neck, can affect the face, can affect the spine, but also they can be peripheral, they can be in the hands and feet and so on. So they can be anywhere. They are not uncommon. Also, so 50% or so, there are different numbers between different studies, but you can have studies show them being as low as 20% to as high to 70%. And I think this depends on the patient population that are being studied, in addition to what investigations was done to look for them and so on. But they are relatively common. So roughly, if you have 1 in 3,000 people with NF1, roughly you might have 1 in 6,000 people person with plexiform neurofibroma. These are they can be hidden. So sometimes we only pick them on whole body MRI or imaging, but they also can be on the surface, similar to this in the thigh or other ones. They tend to follow a benign course, but not always, meaning they typically tend to grow in young age, around 10 years or so. Can be earlier, can be later. They almost never shrink. Some reports of them shrinking slightly in adulthood, but typically this is not the case. And even if that happens, it's usually small change in the range of 10 to 20% spontaneous shrinkage. And I think from at least my experience, that also might be related to imaging criteria or so on. But they tend to be either stable or they can grow with time. So prediction of their behavior, if you see them for the first time, is not always easy. But if you have a person who have plexiform neurofibroma for a long time, that has been stable, chances are that it will remain stable. But still, I think there is more research that has been done, but more is ongoing to understand these tumors more. They can be very debilitating, they can be very large, they can compress vital structures such as the eye, the globe, trachea, plexus and nerves, and so on. So their direct mechanical compression is one of the major morbidity from them. But also you can have other problems such as pain related to them and potential to malignant transformation, as well as others. And they basically can happen anywhere as long as there are nerves. Neck, leg, spine, buttock, all of these are potential places. And there is a risk of malignant transformation for these tumors. Also, numbers differs. To me, I think the range is in about 10%. These become malignant, but some of the studies showed significantly lower numbers of potential malignant transformation. And this is another topic that is also complex. The signs of malignant transformation are typically rapid growth of the tumors, as well as a significant change all of a sudden, including pain, a change in the texture, a change in the skin, associated other symptoms that might also hint to metastasis, and so on. But to us, rapid increase in size or rapid increase in pain is a worrisome sign for malignant transformation of these tumors. And if that happens, it can be a nasty cancer. And there is an area in between malignant and benign that is also tough and under good debate about the best diagnostic criteria for these and what to do about these situations. Now, eye is a major issues with the orbital disease. I think I have few examples here that can be either isolated to the eye or it can be orbitofacial, and it can happen at any age. This is a patient of us who had almost completely lost his vision on his right side. Now he goes to school. He has significant pain because of this lesion. And this patient recently, I don't have the picture, had surgery and really did not show significant benefit, in my opinion. So no significant reduction of the tumor size, which is usually an option, but is not always the best option. And we are going to talk about this later in the slides. These tumors tend to be highly vascularized and they tend to be infiltrated by nerves, and they also can recur after resection. Some of these tumors might be good for resection in the right settings, but some are not. This is a patient of mine. I don't have the pre-op images, but he had also resection of relatively larger plexiform neurofibroma than what you see. But he was happy after the surgery. His pain had decreased to some degree, but I think the outcome was not as optimistic as we were hoping. And this is one of the other challenges we see with NF1, specifically Plexiform neurofibroma. This is a lady who has this huge neck mass compressing the trachea, and she's tracheostomy dependent. This is a lady who has it in the knee, for example, which is limiting her mobility and causes her pain with walking. This is at the ankle, which is to this patient relatively benign. I always have this picture because this report says that this is a vascular malformation and tissue biopsy is recommended, which is something we wouldn't recommend. In the right clinical context, radiologists can, for the most part, tell that this is a plexiform neurofibroma, and we typically don't recommend touching these unless you suspect malignancy and you need tissue, and that should be directed exactly at the area where you think that there's malignant transformation based on imaging and functional imaging. Or if you want to go for resection of these tumors. Other than that, we don't recommend biopsying these lesions. So even radiologists, they have to have the clinical pictures in order for them to catch the diagnosis, because even radiologically, it can be misdiagnosed. And this is with Dr. Fatima and multiple other colleagues in our region from different specialty. We try to catch and refer patients and build an F1 program to solve many issues. But one of the most important one is for us to catch this patient population at early stage, at young age, to prevent long-term sequelae of this potentially a significant disease. And this is a patient of mine who has plexiform neurofibroma throughout his body, in a bad shape, significant pain. And this is a stage also that even the newer treatment, we're not so sure about the efficacy in such situations. And NF1 is it's a multi-systemic disease, and every subspecialty, if you have someone who is interested in NF1, they will know knowledge about it that you didn't expect. Or you are not aware of. If I sit with ophthalmologists, talk with them about NF1, they tell me things that I wasn't aware of, or what is the best investigation, or and so on. And we're going to circle around that later, but this is the importance of having NF1 multidisciplinary teams and programs to look at these. But this is an example of a patient that we saw a couple of years ago who had a cerebellar tumor. He underwent surgery and was referred to us from radiation, who were planning to treat this patient with radiation, and they asked us to see if the patient is eligible for chemotherapy. But if you look at the patient clinically, if you look at imaging, this patient had enough diagnostic criteria to call him an F1. So we called radiation, we stopped the radiation. In my field, NF1 associated glioma are different from the gliomas we see, and we manage them differently. So we did not do radiation, which we strongly don't recommend in NF1. And we basically watched the patient, and he did fine. So this is an area in my field, but if you look at NF1 associated, for example, scoliosis, when I speak with a spine surgeon, they tell me scoliosis in NF1 is a little bit different than your regular scoliosis, different management approach, and so on. And this is the importance of NF1. If you look at its genetics aspect, if you look at the long bone complication of NF1, it really had to have someone not only subspecialized in that field, but also sees a lot of cases of NF1 and is familiar with NF1 related specific complications. Um, so I always says that NF1 burden of disease is significant, but it's not only for patient, not only for their family, but also for physician and providers. It's not always a straightforward disease. It is really, really complex, multi-system disease that needs significant collaboration with different teams to come up with the best treatment plan. So, but I hope you could see from what we shared so far that it have a significant social, psychosocial, mental burden, and this also is significant on caregivers, especially for young age and pediatric patient who often have multiple questions but don't have clear answer to, or don't know someone who can help him or help them with these answers. So, and if one in adult and pediatric, NF1 associated plexiform neurofibroma in adult and pediatrics um, uh, had really significant unmet need for very long time. And we are happy that for the past 4 and 5 years, we have now new systemic treatment that is changing the approach to these complications, and hopefully in the future we'll have even more. There are a lot of promising stuff that is coming on the way, inshallah. So, in the effort to serve this patient population better, a large group of different physicians, initially mostly pediatric focused, then adult, met. We came up with diagnostic criteria for NF1, as well as management, screening, surveillance, and we tackled other things that is important in our region. This is a study you can refer to, but I'm not going to go into details about it. But we also tackled not only the surveillance, but the referral pathway. We worked with MOH to establish a referral pathway. Still not yet really active, but it is being worked at. If anyone have interest in this too, we always look for more collaboration. Dr. Fatima, myself, or anyone in the NF1 family can help, as we are currently working also with MOH to uniform the NF1 pathway for pediatric and adult, which we have proposed several years ago, but it's not yet really active. We have recommendation for optic pathway glioma management, surveillance, and so on, in addition to other disease manifestation. We try to cover all aspects of NF1. And this is the initial proposal of the management of NF1 associated neurofibroma and plexiform neurofibroma. I'm not going to go into details about this because it is, in essence, this is relatively different between different health systems and what is the availability in the specific health system. But we highlighted what needs to be urgent referral, what could be referred in normal settings. And this is mostly focused on the pediatric population rather than the adult population. If you have any question, I'll be happy to answer at the end. I'll jump now on, as of now, the only approved systemic treatment in Saudi Arabia for NF1 associated plexiform neurofibroma is selumetinib. It was initially approved for pediatrics and then was approved in adults. The pediatric approval came from the SPRINT trial, which was two parts, two stratums. The first one tackled patients with symptomatic plexiform neurofibroma. The second one with asymptomatic, but potentially symptomatic plexiform neurofibroma. These are the details of the study. This is the dosing, which is what we do in our practice. And with these relatively uncommon diseases, most of these studies are done with relatively smaller number of patient population compared to what we are used to in especially in my field in oncology, in other treatments. So the objective response rate was a reduction or shrinkage of tumor size, and the partial response was set at 20% reduction. There is a long story about how did that number come, but I think this is our standard now for primary response in plexiform neurofibroma, which we will expect with multiple other studies that will be coming in the next few years. But in this study, there was 50 patients, and this is the area of involvement of plexiform neurofibroma on the right side, and their manifestation, including disfigurement, motor dysfunction, pain, and so on. In this study, in pediatric, the major overall response rate, which was, I think, better than expected based on other studies, reached about 70%, who reached 20% reduction of plexiform neurofibroma size, which I think was pretty good, especially compared to what we'll see later in the adult population. And what we know is that some of these patients will achieve that response relatively early, especially when it comes to pain, which is a secondary endpoint. These patients who have pain tend to respond pretty early, most of them. Tumor shrinkage wise, you can have some patients who respond early, but some of them will be late responders. And this is another important point. When I meet families or patients and we want to start treatment, I tell them this is not a magic drug. If we're starting treatment, we need to wait pretty long time, sometimes 2 years to see a response. And that's why, at least in my practice, I don't do imaging frequently unless I have another indication. But typically, what we do, at least in our center, we do MRI once a year for these patient population because the response tend to be delayed. And if you do earlier imaging and you don't see significant response, this does not exclude response, especially that if you achieve another objective find or another objective from the treatment, such as pain. Now, if you look at the time per cycle and the response, the longer you do the treatment, the better the response. This is the response rate compared to natural history based from other studies. And this is the complication. To us, oncology, we are very familiar with these complications. We use MEK inhibitors a lot. Even for brain tumors, we see it in other BRAF mutated tumors, and we use it with combination with BRAF inhibitor. Typically, MEK inhibitors affect the skin and GI. It can have also hypercikaemia, can have headaches. Sometimes you can have fever and other manifestation. Generally, well tolerated. You can run into grade 3 complications, bone marrow suppression, rash, which also tend to be problematic in some patient population. But in good centers, for the most part, these complications are dealt with without problems. You do, though, need to be familiar with these medication and know how to manage complications. Because we use them frequently in other kind of cancers, and then these TKIs tend to share complications and adverse event. Now, in the adult population, the study was done differently. It had a placebo arm compared to a treatment arm, and switched to the treatment arm. The placebo was allowed at after cycle 12, and this included patients who are 18 years or older. Similar overall primary and secondary endpoint, looking at quality of life, pain with the same primary endpoint. Different PROs were used for quality of life assessment. I'm not going to go into details about this, but if you have any question, please let me know. The response rate in the adult population was significantly lower compared to the pediatric population. You're talking about 20% response rate to almost 70 in the pediatric, and this strengthened the idea that treatment should be started at earlier age rather than later. Now, one major question remain in non-responders in adult, how fast you can judge or how soon you can tell that there is a failure of treatment. This is, I think, at least to me, is an unanswered questions. To me, I usually tell patient at least 2 years to maybe 3 years. If we don't see improvement, then we probably are non-responders. But this is a question that we don't have an answer to. And I believe, this remaining 80% potentially can have a response if you go beyond 16 cycles, but we don't have a good answer to this. Some studies have shown that, but this is a little bit debatable. I think we don't have good evidence on that. The other point that we need to mention is that even in this trial, you see placebo effect, and there are, few patients who did have response in the placebo arm. And I think if this tells us something, that the volumetric MRI assessment for plexiform neurofibroma is not 100% accurate. This is also another point to tell us that response is not always what we see on imaging or what does the patient feel objectively, but also If you have other endpoint to look for example, if a patient is tracheostomy dependent who was able to close the tracheostomy, or if someone have significant pain, if someone have improvement in vision or proptosis or so on, even if you don't have objective volumetric imaging based response, it doesn't mean that these patients are non-responders, at least to me. And we have patients who only responded pain wise, and they are still on treatment, which I think to me is a good response. Some other details in this study, there are many things to share, but as you can see, good percentage of those patients who did not achieve primary endpoint did have some reduction. So this is what we were referring to: the longer the treatment, potentially the better the response. Now, secondary endpoint were not achieved. The important one, which is the pain and quality of life overall. In clinical practice, to myself and many other colleagues, we do see some pain improvement or need to reduce or ability to reduce other pain medications such as gabapentin, pregabalin, and the other ones. And this is something we do see in practice. So even negativity in the study, I think in real practice and real life, we do see some improvement in pain. Adverse effect, as I mentioned, similar to the pediatric, you can get rash, you can get paronychia, you can get edema, which is something we see often. For the most part, manageable, but it does need someone to watch for them, to see the patient closely, and know how to manage these potential adverse events. Now, I'm going to quickly shift gears about the NF1 program and specialist center. If you come to the region, in the Gulf region, 5 6 years ago, there are no NF1 programs, no NF1 specialist. A lot of physicians who really have patient in NF1, but in my honest opinion, there was some disconnect between the providers. But in the past few years, we uh, with the help of different groups, achieved something remarkable, in my opinion. We started working together from different specialties, from significantly different specialties, at least 10 or more specialties. Network was established. NF1 program started popping around. In Riyadh now we have more than one. Jeddah we have. Eastern region we have. Even in the Gulf area in UAE we have. Qatar also have. So this was, I think, in my opinion, outstanding achievement over the past few years. You have people to contact from different areas about NF1, and you can share experience with also different providers. And I think this is the beauty of NF1 centers. These patients get to know physicians in their area to work with. And I think this is the most important message from my presentation today, is that these patients get lost in the system. Pediatrics do, but adult, they are in a worse situation. A lot of them are not following with any physician or one physician for a specific complication, and they are unaware of treatment or unaware of centers that are dedicated to help them. Um, Even if you go to the US, a significant number of patients who even were involved in pediatric NF1 program, once you go into adult, you lose you lose this network. And in the US, there's only about 20% or so of patients who were treated in the pediatric group NF program, lost to follow up in adults. So, what we did in at least our center is that we
شاور من البيت. إيه هذه هذه فيه تشاور من البيت.
موجودة هنا؟ خليها باكر. Hello. Uh, I'm not sure who's sharing this. Um, دكتور مساعد.
أيوة.
Yes, I'm not sure who's sharing this actually.
Okay.
I will.
I can continue.
Excuse me. Can you Dr. Fasih, can you remove this participant, please? Just a minute.
برا حلو بعد برا حاطين 16 مكيف الله 16 يعني في
Excuse
كل
me. دكتور
أكو يعني
فصيح.
قلت له وطي لك مرة قاعدة وبعدين
Yes, Doctora.
Yes.
Mr.
Can you?
Talat is there. Talat is the one handling the technical thing.
Okay. Can you
Talat,
I think maybe continue.
Yes, please continue,
So,
Doctor.
so the other, almost done. The other thing we want to talk about is that the design or the model of NF1 clinic is not consistent and does not to be need to be consistent. Basically, you need to have providers who are interested in NF1 program. Once it starts, it can be reshaped based on the need of the center. And I think this is a key point that we learned reaching to other centers, mostly in the US. So what we did in King Faisal and Riyadh, myself and Adda Neuro-Oncology, Dr. Hannah from genetics, and Dr. Msaad Abu Khalid from pediatric neurology, we started the NF1 clinic. We wanted it to be combined, adult and pediatrics, and we wanted to be open to all. And we wanted the referral system to be very easy. We wanted any physician who want to refer a patient to just put an order, and that's it. We will see the patient in our clinic and we will take care of everything. There is no need, to call us. There is no need to send us anything. And we also stress on seeing adult and pediatrics in the same setting to help families. A lot of families have adult and pediatric members affected, and also to share experience with each other. So this is how we started the clinic. It has been running good. Still, you always run into issues in clinics, and I always, share with my colleagues how what we did and how we fixed some issues that we run across. If you want to start in a clinic everywhere in the world, you will run into problems. So we'll be happy to share our experience with whoever have any questions. But at the end of the day, you cannot manage every complication in a phone clinic. You have to rely on physicians from different specialties, and this is an example of some of them. In our practice, we have good relationship with almost all of these specialists, and we try to have one person who help us and becomes our NF1 expert in that field. Spine surgery, we have one spine surgeon who's working with us. We refer cases, we discuss it with him. Sometimes they come to our NF clinic if we have a patient or questions. Dermatology, the same thing, ophthalmology, and so on. We try to optimize other things, but still, it's not always as easy as you hope. For example, we wanted one radiologist to read all whole body MRI we do for all of our patients, still not being done. So you cannot always have it perfect, but this is our thinking and this is what we are working on now. And there are a lot of things to tackle in your system, which will be different from other systems, including the referral system, triage, how does the MDT works, how often you do see patient clinic, do you treat them with systemic treatment in the clinic, or do you refer them to someone else, and so on. So these are things that also are different from different NF1 clinics, and I think it shouldn't be the same system in in every health system. I think if you see many successful NF1 program, they have different NF1 structure, NF1 MDT structure, which I think is okay. And that's all I have. Thank you so much and happy to receive any question.
Thank you very much, Dr. Saad, for excellent and very informative presentation. Actually, we have received several interesting questions from the audience, and I would like to move on to the Q&A session. So let's begin with our first question. There's a question: when orbital plexiform neurofibroma causes ptosis or proptosis, when do you recommend systemic therapy before surgery?
So, a good question. We discussed in our MDT, and we discussed with the surgeon, ophthalmologist, what is the chances of this being completely resected or getting meaningful resection and functional recovery. It's always case by case. And I always tell the surgeon that, when we start systemic treatment, I don't expect to see improvement immediately and potentially no improvement, especially when it becomes, older population, in addition to potential recurrence with surgery. So it's always a case by case situation in the MDT setting.
Yes. I have a question. If the proptosis or the ptosis is operable, is this patient eligible for this medication for the targeted treatment?
I think yes. It is always, if the ophthalmologist tell me that this is something we don't want to wait on and we can operate, I think this is reasonable. If it's something that the ophthalmologist is happy waiting on, we always prefer systemic treatment before surgical resection if we can. So I think it remains case by case, and I need the expert opinion of our ophthalmology colleague to tell us about this. We know the efficacy of our medication in plexiform neurofibroma. However, the direct compressive effect need the expert opinion of the specialized person who is managing that. If you have a spine, I also sit with the spine surgeon and discuss this with them. So it's always, a multidisciplinary decision.
Yeah, it's very helpful point because the criteria now it should be inoperable or they depend on volumetric MRI. Although there are many patients they have this proptosis or ptosis, and even when operate on them, there is high recurrence rate. So it's very helpful point. Another question. What baseline ophthalmic assessment and ongoing monitoring do you recommend for patients receiving MEK inhibitor therapy?
Good. So this is up to the ophthalmologist. We always ask, at least what I do is slit lamp exam and OCT. They have to have that with every visit. We do it annually in our center.
Yes, okay.
Visual field, our center, they don't always do it, which
Mhm.
is fine. I think it is important for the optic pathway glioma age bracket.
Yes,
But for cilimetrin related, my ophthalmology colleague don't always do it. They focus on OCT more, and we live
yes.
up to their experience, yani.
Mhm. The OCT because of the risk of the side effect, retinal
Correct.
pigment. Yeah,
Retina, correct.
yes. Another question. In patient with a plexiform neurofibroma, what clinical or imaging features promote you to recommend systemic therapy rather than proceeding directly to the surgery?
Okay, so the practice differs, and in our center, any patient who is 40 years or younger, we do for them whole body MRI. Usually, this is our first step, and then we do targeted imaging on the area of interest. You can have symptomatic, you can have asymptomatic, you can have operable, you can have inoperable. The definition is not always very clear, and the criteria is not always very clear. The maybe some of the examples I show you is for extreme cases, which was to some degree clearly inoperable. The trachea case I showed and other ones. But if you have some potentially operable ones, it can be a good option. We have several examples of patient with spine plexiform, older patient. We did for them surgery. We relieved the compression. They are doing very well. They did not need systemic treatment. So to us, it's always MDT, and this is what I stress on always. I sit with a surgeon, I sit with ophthalmologist, I sit with the spine, and we discuss with them. If we expect good surgery, we tend to go with that, even if it's asymptomatic but is growing. So it is case by case, and I think this is the most important point of NF1 programs.
Thank you so much. There is another question. Is there a biomarker may predict the response?
As of now, no. Earlier response is usually a good indicator, but no clear response. Even, parents and patient ask me, because in the studies, you can also see response in the cafe au lait macule, you can see response on the cutaneous neurofibroma. We really don't have really good indicators for response. There are ongoing studies on um, response and progression in NF1 plexiform or cutaneous neurofibroma based on genetics as well as functional markers, but they are not in use in practice now. So usually time is our best indicator.
Yeah, thank you. Another question. After achieving a good response to MEK inhibitor, when do you consider reconstructive or debulking surgery? And also, when do you consider discontinuation of the treatment?
Very tough questions. And I mentioned this in the presentation. Discontinuation, not a clear answer for now. And also, it depends on the patient themselves, their wishes, because I usually sit with them, their family, and discuss this with them. If the tumor remains sizable, we tend to continue, especially if there are good tolerance and so on. So when to stop? No good answer to that question. I think if the patient is responding well, tolerating well, probably continue for pretty long time. Um, Doing MEK inhibitor for a certain period to facilitate surgery is also an option. Many centers are doing it. Some surgeons also report that being on MEK inhibitor, once they operate, it makes the surgery easier sometimes. So this is why I say you have to have a surgeon who deal with plexiform or NF1 related complication. I think some of these questions we still don't have very good answer to. Maybe in the future we'll know more about the answer to these questions. Because evidence wise, it's mostly anecdotal for now. There's no good evidence in that regard.
I have a question. What is the longest period of treatment you have for your patients?
About 3.5 years or so.
Okay. And they are still tolerating with manageable side effects.
Well, that patient is actually a nurse. I started her treatment when she was in college. She had a buttock plexiform neurofibroma. She was unable to sit. So she attended college standing. With the treatment, the pain significantly decreased. Up until today, the shrinkage is not very clear. It's very large plexiform and diffuse, the diffuse type. So these are the ones that it's tough to do them volumetrically. If you look at our radiologists, they report them as stable. Every time I look at the scan, I question if there is improvement or no. She did have significant pain improvement though, and she at some point developed bone marrow suppression. We stopped the medication, and then we went back. We stopped it again for short term, and then her pain reemerged. So I know definitely pain control was a good part of MEK inhibitor with her. We did not achieve good shrinkage as of now, but we have good outcome, decent outcome. I would
I
say.
think quality of life is a very important point in these patients. Maybe a last question. If I identify lesion nodules or suspect during routine practice, at what stage should I refer the patient and to which specialist or multidisciplinary team?
Yeah, this is I think the main goal of this talk today. Yeah, you should find or look for an NF person to refer to. And it depends on the system you are. I know MOH, at least in Riyadh, pediatrics, they have NF1 program. You know, National Guard, they have NF1 program. Here in King Faisal, we have NF1 program. We accept referral from everywhere. So if you want to refer to us, we'll be happy to see the patient. But I think in the health system you are in, try to find an NF1 person to refer to. Our doors are always open for any NF1. But then I think, this is challenging in the private sector. Many of our referrals we get from the private sector. But in the non-private sector, I think there are ongoing efforts for NF programs in many centers. I know in Jeddah there are many now.
Mm. Thank you so much, Dr. Saad. Actually, I'm one of the referring doctors for you,
Yeah.
and you was always welcoming my patients.
Yeah.
And thank you for a highly important, informative presentation. We greatly appreciate you sharing your expertise and practical experience with us. Thank you also for everyone who joined today's webinar and for thoughtful questions. We hope found this. We hope you found this session educational and clinically valuable. So, on behalf of SOFOA and SOS, thank you so much, Dr. Musa'ad, and thank you for attendees.
شكرا، فاصلة كريم، الله يعافيكم.
الله يحييك.
مع السلامة.
مع السلامة.